Welcome everybody to the Random Anesthesia Topic podcast. In this episode we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Giulio Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. All right, welcome everybody to special episode number 2. Tonight we have with us Dr. Giulio Menciotti from Virginia Tech. He's an assistant professor of cardiology. Welcome to the podcast, Giulio. We're so grateful that you're here with us.
Thank you so much for inviting me.
So I met Giulio probably like a year or two ago. I was locuming at Virginia Tech, and he's one of the coolest cardiologists I've ever met. So I'm so grateful he's here. Even though he was late, it's totally fine. We'll forgive you, Giulio. We'll forgive you.
I was like 20 minutes late. That's within the realm of cardiology. On time.
No? That's the
I'm holding
payback.
my judgment until we hear how he feels about Dexmedetomidine.
I knew this was going to be like a major topic today, so I'm going to blame the language barrier whenever it comes to it.
So,
That's
Tasha,
okay.
do you want to
translate from Italian? So you're fine.
Oh man, I cannot.
Do you want to fire at it, Tasha? Go for it.
No. Keep going with the introduction. Like, do you want to rock up hot, or do you just want to like ease into it with something like ketamine,
ease into something like ketamine
or dobutamine with pulmonic stenosis?
Oh, he loves it.
Like right out of the gate, Bartel.
Yeah, you know me, right? Got to get them while it's hot.
So yeah, I heard that you love dobutamine with pulmonic stenosis cases, right?
Yeah. Well, that was an interesting thing. I was talking with Gianluca when he came to locum at our institution, and I was in a pulmonic stenosis case, and I have to admit I'm a very nice person. I'm a very nice cardiologist, and so I don't care too much what the anesthesiologists do. I almost never ask what the dog is on or anything.
Great, we prefer that.
Until I was literally unable to keep a flow-directed catheter, like a Berman, into the right ventricle of a dog because it kept shooting up all the way to the branch pulmonary artery, one of the branches, every single contraction. I was like, why is this dog has like a ejection fraction of like 170%?
No big deal.
You're welcome.
I was talking with Gianluca about this story. It wasn't him on that case, to be fair. Although I feel like he would have probably done it just to piss me off.
Oh, 100%. I would totally piss you off. So, but let's get into something serious. So, we often anesthetize cases that have, cardiac disease, right? And so one of the things that, always comes up is we always try to keep a good blood pressure, even in patients that, for example, like with pretty severe mitral valve disease. Sometimes it's really, really, really tricky because if you can increase contractility and that may work fine, but a lot of the drugs that we use to increase contractility, they also increase a little bit systemic vascular resistance, they vasoconstrict a little bit. What's your thought on that? Like I always suggest like something like dobutamine for these cases, right? Like because it increases contractility, but then dobutamine sometimes it vasodilates dogs, right? And so the effect on the numbers on the screen, it doesn't look as good, right? Like I'm like, okay, I increased contractility, cardiac output's better, blood pressure didn't fucking move, right? So what's your thought on that? Like, is blood pressure actually, we always say that correlates with perfusion, but is how real is that, right? Like, is it really?
That's a very, very good point. And although with mitral valve disease, I think we have ginormous spectrum of patients, right? Somebody, virtually any medium small breed dog will develop some degree of mitral valve disease in their life, and so we got to differentiate the patient that just received a pre-anesthetic echocardiogram because the owner was concerned, or you're working in a place in which everybody with a murmur gets a pre-anesthetic echocardiogram and gets diagnosed with a mitral valve disease at a very early stage, versus a dog that is actually a dog that we would not recommend any elective procedure, like a heart failure dog that has got a ton of mitral regurgitation and then ends up like being like the classic dachshund that is now a back dog but is already like a bad anesthetic candidate for starting with because he's got bad mitral valve disease. I think they're very tricky patients. I also think they are very sturdy patient, though, if you wish, compared to somebody with other type of cardiac diseases, meaning that contractility in small breed dogs with mitral valve disease is usually very well preserved, right? And so you are playing with a patient that pretty much every time his left ventricle contracts, is shooting blood partially to his organs, but partially back into his left atrium. So I think actually a degree of vasodilation is great in terms of cardiac output. So you got there so much so that when they are in very advanced, like stage D, what we call like refractory heart failure, we will put these patients on amlodipine, right? Because their left ventricle is always has two outlets, the left atrium and the aorta, every time it contracts. And so if you decrease the systemic vascular resistance a little bit, it's going to be increasing forward output, even if your mean arterial blood pressure doesn't move much, right? But those are those cases in which obviously that dichotomy of the blood pressure being an index of perfusion is probably not very true in that case, because you're still perfusing more by vasodilating them a little bit, particularly with the butamine, in which you're increasing contractility, and at that point you are at the risk of increasing the regurgitant fraction a ton, and so you could actually push them into left-sided heart failure. And then the other odd entity, though, caveat to this is the larger dog that has got mitral valve disease. We know that large breed dogs, they tend to develop systolic dysfunction along with mitral valve disease. So in those cases are the ones that I would actually favor if I can have a choice. And most of the times I don't have a choice. I'm not. I can have an opinion, but it may or may not be taken into account into anesthetic consideration. I still put them in my report, but yes, that's where probably.
Okay. Now we're getting into this. We're getting into this now, right? So the fucking cardio report, right? So every time we see that, right, and you get this cardio reports, and it's like, cats with HCM, and they tell you shouldn't use Dexmed, and I'm like,
shut up.
Okay,
shut
I'm like,
just shut up. That's what I'm like.
So like, a lot of those is like, don't use this, don't use that, don't use this other one. What the hell do we anesthetize them with?
Okay, I'm going to have to interrupt here because I'm not sure I can take this much longer. So first of all, that's the longest the three of us have ever been quiet as a group together. So that was like our own personal world record. But I mean, Beanie, I see the cardiologists make unhelpful little remarks, things like be careful with fluids, which is a meaningless statement. And I think one of the things that I take issue with is that, and it's not just a cardiology thing, but I find a lot of people have opinions about anesthesia when they don't perform anesthesia. And then when the shit hits the fan, everyone goes hands off and hands it over to us, right? So
this is what they ask us. When they come to us for
anesthetic
recommendations. You know how much I
That's
would love.
different. I'll give you that. When you make a somebody asks, then you can have an opinion. But a lot of the times, what is written in a cardio report is an extremely restrictive and makes us liable. And often the statements are meaningless, like be careful with fluids, right? Like judicious use of fluids is a meaningless statement because it doesn't tell you rate, total volume, it doesn't tell you the type of fluid, it doesn't tell you, it's never based on and I agree with you, it's the degree of heart disease that I take into consideration when I make distinguishing, pharmacological or other treatment decisions. But yeah.
Oh, I also
Cardiology advice about anesthesia doesn't tickle my fancy.
just in terms of I've saved this for years now. It was a cardio report from a cardiologist who had seen a cat. The cat was diagnosed. Let's see.
You actually have it saved?
Their assessment was the cat had dynamic outflow obstruction, but they mention in their induction it should be with an injectable such as propofol or ofloxacin. Although gas induction with isoflurane and sevoflurane is also appropriate, which I've never met this cardiologist. It was just a record I was reading. And it was a recent one. Like this is in 2019, so it was recent enough. But I was shocked at the quality of report that was being submitted.
In the words of Tony Soprano, get the fuck out of here.
No,
I mean, the cat was super fractious, maybe, but like,
you know how much I would love not to put an anesthetic recommendation in my report and just give the numbers. Like just ask for it and I give you the numbers and you guys work it out. Like that's great. Not even the diagnosis or anything. I just give you the numbers. That's awesome.
Love that. That would be.
We are grown-ups, and
I want to see all the numbers. I get so aggravated when cardio's like, "Here's my words. Like, here's a paragraph of words," and I'm like, "Where's the? I want to see like the fractional shortening. I want to see the ejection fraction. Like, give me the numbers. Like, how is the heart doing?"
I gotta bounce the ball back in your yard, and this is my favorite question for anesthesiologists. They would have like a dog with mitral valve disease, and they would come asking like, "What is the ejection fraction?" It's like, what are you talking about? It's not a disease that affects the ejection fraction. It's like 100% in these dogs. They're actually hyperdynamic. The ejection fraction is not your problem. The problem is that the blood is not going in the right direction. It's not how much the patient
we want to know it's getting out.
Anyway, no, they never burn out, small breed dogs. They die with an ejection fraction of like 85%. Okay.
Oh my God. You know what? This is I would like to hear all the things that anesthesiologists do that annoy a cardiologist. Let's get
Yeah. Let's do it. Let's do it.
Let's go this way. This is wildly entertaining. Yeah, tell us, what do we do?
I think the ejection fraction is like on the top of the list because the vast majority of the disease, except for like DCM, the disease that we deal with on a daily basis, they actually increase ejection fraction. If you wish, like a dog with HCM is got an ejection fraction, if you were to like really calculate it, close to 100%, some of them, because the ventricle is so small that it squeezes to empty. But the same for mitral valve disease. But it does bring up like an interesting point is that I think out of many other specialties we are the ones with a lot of well-designed placebo-controlled clinical trials and stuff like that, meaning just that it's overall, I think it's a specialty that likes to work on evidence-based data. And when it comes to anesthesia, we actually have close to none. And so we were discussing just today with my colleague how it's true that sometimes we put stuff in our report and it just reiterated just because people copy paste previous report, like for example, like the ketamine is like a good example, right? And it's just because theoretically, it's reported to be pro-arrhythmic, and we know that these diseases, some of them, they are also pro-arrhythmic. So it's just trying to stay on the safe side, and then sometimes they get escalated. It's kind of like, when somebody says something and he starts like a lizard and it ends up being a crocodile and it gets escalated with like, absolutely do not use this, otherwise this patient is gonna die. Now, I do believe that a lot of these things, they have a lot of theoretical basis, but not a lot of practical evidence-based medicine behind it. And my come to Jesus kind of moment A few years ago, we were doing a research stuff with a human cardiologist, and it was a bunch of people from a very, very important nationwide institution. And they came to us with a double boarded criticalist cardiologist, a pediatric criticalist and pediatric cardiologist, a cardiac surgeon, a perfusionist, and everything. And then I was asking them, like, oh, what do you put these kids, not even kids, like infants, on when you do cardiac surgery? And he was like, oh, ketamine Dexmed usually. Is like, what? Like they like leave on like no ketamine, no Dexmed, right? And so I do have more of an open mind about that for some of these conditions that some other cardiologists, I guess.
For those of you listening, by the way, you can't see the three anesthesiologists all holding their hands in the air and cheering while these concessions are being made. Yeah, 100%. Yeah.
I have to say that a lot of these patients are on cardiac bypass anyway, so nobody cares about their,
They're just bubbling.
there's a machine perfusion
Absolutely.
for them, so it's a little different.
I mean, I always say too, right? Like, based on the combination of drugs we use, and you know what, under anesthesia, I can't even think of a drug that I probably have not potentiated a dysrhythmia with at some point or another.
Yeah.
And I'm sure it's the polypharmacy as a component of it. I always think that the inhalants are usually like the baseline problem for most things, especially cardiovascularly. But yeah, I think, that's I think sometimes when we struggle a little bit with those little helpful quotation mark tips from cardiology is that, if you take away a drug or a drug class as an absolute, it takes away our ability to practice from experience and with the art of anesthesia. And, and I understand a lot of times cardiologists make recommendations because that report might be going to a general practitioner who doesn't have an anesthesiologist, what have you. But yeah, like I said, I mean, I've given things dysrhythmias with pretty much every drug I can think of, including antibiotics and antacids. So,
Absolutely, and I think one of the things that came up talking with Gianluca when we were chatting together, it's very true that actually the monitoring makes a world of difference, right?
Yeah,
Like
if you don't monitor them, then you don't worry about these problems.
And so, and I tell my residents, or in general students as well, it's going to be extremely different if you anesthetize a patient and you're like inflating a Doppler cuff every 10-15 minutes versus you have an invasive arterial line and you can correct stuff right away. Because it's some of these patients, you may get in trouble, and by the time you realize you got in trouble, you are like way too far gone to rescue them if you don't have appropriate monitoring, right? So I think you're right that a lot of the reports in the field, they are overly cautious because of that, because we don't know in which hands these patients are going to end up with, and so better to be safe. Although, yes, sometimes we do exclude all the options. So what are you?
Yeah.
What are you gonna use? We like our acepromazine, we like our butorphanol, we like our. I know that much. And
it is hard to kill things with butorphanol. I will tell you that. It can be done. But you have to make an effort. But yeah, I mean, one thing too is that like I've practiced in countries too where they only have access to like a very limited number of drugs too, and so you basically like if you ain't using ketamine, you ain't using anesthesia,
Right.
and you're basically putting 100% of your patients down without an inhalant and only injectable. And if we're calculating the percentage of those cats who do have HCM and how many of them are dying from it, it's super duper 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 small. So these absolute contraindications, like I said, they do tie your hands and they kind of crap.
Wait, you're saying that you actually have seen cardiologists making absolute statements in the report? Because we have perfection, the art of being wishy-washy, I feel like.
No, guys, that's
I would not do that. I would not recommend that. Is most likely this, is most likely that. But we're kind of like second only to pathologists in that art.
And radiologists, don't forget that.
Radiologists, yeah, this is most likely this. So I would avoid that if possible. But
Yeah.
I think what
No, I have some cardiologists who've made absolute statements, but like I said, if you're working in an environment where you only have 3 drugs in the toolbox, like the whole principle of like the cautiousness is irrelevant. And like I said, a lot of people use these drugs in the face of those advisements, and mortality in our hands is still ridiculously low. So
yeah.
I agree, but also, like, again, bringing back the point that I think we may have a skewed perspective of a lot of people that know what they're doing very well, right? And they have a deep understanding of the interplay of these systems versus the vast majority of people that anesthetize dogs and cats, which are not board certified anesthesiologists and may look at numbers that are not even real, right? A heart rate that is double counted or half counted, a Doppler cuff that is not even on the patient. Like, you know what I mean? And I'm sure that everybody's trying to do their best, but I think
only
some of
Ryan
these
likes
recommendations take into account.
only Ryan likes Doppler. So
Christine also likes Doppler. She texted me to say how much she loved my comment on the Doppler.
I just want you to know that a handful of the humans that I know, that like the human medicine people, so I've got like a couple of anesthesiologists, respiratory therapists, and criticalists who listen to our podcast because they find it so weird, the things that we talk about and anesthetize. And they were blown away when you said Doppler, and I don't mean that in a good way.
Oh, I'm absolutely sure. I also just want to mention I had like a epiphany moment too when I spent a week in the human anesthesia wards and they were doing like coronary arterial bypass grafts. And so like humans going on like who are going to go on cardiopulmonary bypass, but they're not there yet because they have to anesthetize them to place the drains and pumps and all that. And they were all on dexmedetomidine CRIs. And my little brain was just like, what? Like, these are like sick ass patients. And they're like, oh yeah, like because they've got, coronary arterial disease and we want to slow their heart rates down and like increase, diastolic time, blah, blah, blah. And I was like, wow.
Yeah, but I've had that epiphany with the human groups too. But I also think that we are dealing with these patients are instrumented head to toe.
Oh yeah. And
So
their
that
disease process is different than what we
and
see.
disease
Like,
exactly are
we don't
different.
have
Right? And
coronary artery disease in dogs that I know of, or at least like if we do, it's
Yeah.
incredibly rare.
yeah, no, almost inexistent, really, even with advanced diseases that should cause coronary disease. I don't know. I think we should maybe try and start feeding them burgers and chips and see if that pops up, because otherwise we found a cure for coronary disease, right?
Canadian, if there is going to be a country where there's a subpopulation of coronary artery disease in dogs, it'll be America.
Probably.
It's true. I was gonna say, I think a lot of our patients are probably coming in eating burgers and fries, and
Yeah. To some
depending
degree.
on where you practice.
Yeah, but then the other thing is the dose that these patients are on, right, for these drugs as well. You risk that somebody that is not super experienced in attempting to treat a number, which obviously most of the time is going to be your blood pressure, not even invasive. Sometimes they keep escalating like drugs that increase systemic vascular resistance in a patient that maybe is actually like having a hard time pushing blood through because it's got DCM and you didn't even know about it, right? And then at that point, again, by the time you realize that that was not a good choice, you're done, right? And so I think a lot of the recommendations actually, and I see how that can make a lot of people
So
upset.
that brings up a question that I have a lot of the time when we're dealing with these like dogs who have probably what's essentially incidental mitral insufficiency, like the dogs who we don't know if they're going to progress, but they have it.
Yeah.
There's a murmur, heart's not big, everything's normal, but they have a little regurgitation. What like, and I'm sure you can't answer this question entirely, but like I always operate under the idea that like if I choose a drug that's going to increase vascular resistance, that dog's going to see more volume. am I going to push this dog in front of me into congestion through, am I going to take what's a normal heart was never going to fail and now push it towards that direction by intensely vasoconstricting them and slowing their rate down?
I think it's definitely possible. I think we have seen that now and again in the clinical settings, in which even like a dog with incidental mitral regurgitation, honestly, even without an anesthetic event, just because he was hospitalized and overhydrated, it can be pushed into heart failure. And then when you treat them, like you decrease the rate, they're fine. So more so under anesthesia, of course, like if you go into that perfect storm in which you increase their vascular resistance, so it's even easier, you increase the regurgitant fraction, and then you even give them extra volume. It's definitely possible. Like that said, you would, I don't know, in my limited, I guess, experience, because when I do these consults, then I don't follow through what they did on anesthesia. But I feel like if they don't do well, then I hear about them, and it's very, very rare that any of these patients they're usually pretty stable. The one with incidental mitral regurgitation, like if they don't even have cardiomegaly, they need to be under anesthesia for like a very long time with a lot of fluids that are pushed through. They're again pretty sturdy anesthetic candidate as long as they're a small breed dog and their systolic function is preserved. Yeah.
Yeah. So I wanted to tag back on, we were mentioning coronary disease, right? In humans, some of those changes in the ST like actually do correlate with myocardial infarct. How much of that is true in our patients? Like, what do we know about that?
Oh, it is. Yeah, that's a very good. That's a very good point. I think though the ST elevation, even in people, is evaluated with a 12 lead ECG, and it needs to be pretty specific in certain leads and things like that, versus the single lead anesthetic monitor abnormality. But at the same time, we do see often patients that have, for example, severe subaortic stenosis that do have those. They have some myocardial perfusion issues, and we know that the long term they would develop myocardial disease because of their crazy left ventricular hypertrophy from their increased afterload chronically, and they do develop ST elevation in certain leads. And then the other place for that in which we will look closely for it is actually acute changes. I think that's way more significant, meaning that you have been under anesthesia and you have been looking at that ECG for a while and it looked the same, and then at a certain point, all of a sudden that ST segment changes. I think that's a very dangerous point, and that should warrant consideration of some degree of perfusion or myocardial work or myocardial oxygen demand that goes a little beyond the mean arterial blood pressure. Because sometimes in like patients with like pulmonic stenosis that are being under anesthesia for a while, we would see those acute changes, and sometimes they degenerate in bad arrhythmias. They're very difficult to bring.
Wait, you're seeing that occur under anesthesia?
Like ST elevation, yeah, absolutely.
Yeah.
So much that the
Interesting.
some patients with pulmonic stenosis remarkably more prevalent in English bulldog and some degree French bulldogs. They would have pulmonic stenosis and coronary artery abnormalities, for which the classic is an R2A, but has been now shown that other coronary artery abnormalities that will cause that. And so they have one of their coronary arteries that goes around the pulmonary artery, which will not create any problem in their life, except when you try to inflate the balloon and you stretch the pulmonary artery, you actually completely occlude coronary perfusion. And so, and so
I don't know when I really dial up that dobutamine to 20.
no,
Yeah, I was
they
wondering if
just
this is
die.
an institutional issue, if like there's more liberal use of inotropes causing more myocardial work in hearts that are already worked, already on the edge of hypoxemia. So
I've personally, I haven't seen that, but I can tell you that for these patients, when you know or you don't know that they have a coronary artery abnormality, one of the thing that you do, for example, is a coronary tolerance test in which you inflate a balloon on the size that you want to inflate, and then you look at the ECG and you see if they develop ST segment elevation, and that's how much that ECG sign is reliable for myocardial perfusion. So
Very interesting.
Yeah, when I was at NC State during my residency, every time we did PS, a pulmonic stenosis balloon valvuloplasty in a French bulldog or an English bulldog, we would always do like a CT angiogram first.
Yep.
Yeah,
and then
we do the same, and I'm gonna tell you something that I kind of it will crack you up, and it's going to be very interesting for this podcast. So, in our institution, we do not have a ECG gated CT scan. That means that the CT scan does not trigger the acquisition of images based on the phase of the cardiac cycle. Long story short, what happens is that you have a lot of more motion artifact with that. And so one of the solution to that is to slow down the heart rate during the CT acquisition, right? And so when we switch to doing rather than a coronary angiogram, which requires access to the femoral artery and is like very time demanding and expensive, we wanted to put these dogs under CT, not having a CT gated, ECG gated CT, we needed to slow down the heart rate. So what do you think is going to be my go-to for a dog with pulmonary stenosis? Well, just give them esmolol, right? It's great. It's going to be a beta blocker. It's going to slow down the heart rate. And sure enough, the anesthesiologists start to pump up these esmolol. And these are dogs that most of the time they're puppies. They're otherwise doing fine because we want to get them before they have troubles from the pulmonary stenosis. Keep cranking up that esmolol and that heart rate would not budge. And so after like 10 minutes that the dog is there, I remember the judge just look at me and like, can I give him Dexmed? I was like, sure. Bottles of Dexmed, the heart rate goes down to like 40 or 50 and then immediately reversed and comes back up. This great. So that's actually one of the strategies that we use now for this dog with pulmonary stenosis during CT scan. So
yeah,
just for the CT scan though, just for the CT scan.
Well,
I run my CRI for my balloon valvuloplasty.
Me too.
Yeah.
You can add it to Martin Flores' work about.
I know.
Cases.
And I'm sure that I would have loved to see some invasive cardiac output data in my work, because that's, I think, to me, the thing that is less convenient. I really like the decreased arrhythmia that comes with it, because I think that's very important for patients in which we are floating catheters in their heart. Like decreasing their arrhythmogenic substrate is super important. So I'm willing to accept that benefit. I'm not sure that in that subset of patients, the mean arterial blood pressure, or in general, the blood pressure, is a very good representation of their organ perfusion, right? Like these are patients that they have already a fixed obstruction. And if you wish, you can think of the cardiovascular system just stretched out as one big loop. And by increasing the systemic vascular resistance, you're actually adding another barrier that your ventricle needs to push through to circulate blood through. And so I accept that your numbers may look good, but I think we are all familiar also with the experimental and clinical data about the dramatic decrease in cardiac output in healthy dogs that receive alpha 2 agonist. And so in dogs that already have a fixed obstruction, I'm a little hesitant to that. Now, from that to say that they don't do well under anesthesia, obviously they do, because the papers tell us that they do.
Well, they do.
I'm
The
still not
cardiologist
sold.
gets like the show on the road with the ballooning, but if you're going to fart around for 9 hours, then yeah.
Yeah, to move your ass.
Well, I'm sure you're familiar with the concept that things sometimes look easy on paper, but in real life, they may not.
No,
No. Like if I haven't seen you guys fucking around for like 2 hours, like trying to put an arterial line, just put the thing in the wall, in the pipe, right? Easy to me, okay?
you're
And
anesthesia.
that's like
Give me
No,
the
the dog you've ever seen because you want to get them when they're puppies and they're still healthy.
Yeah.
to a little bit though, because I know we talk a lot about the fall in cardiac output. And I think what is incredibly important to remember from the point of view of the anesthesiologist, and I always have to tip people off about that, is that the cardiac output, like the drop in cardiac output, and the reason that the patients tend to do well is because anesthesia is basically like brainwave activity aside, but from a physiological point, cardiovascularly, pulmonary, gastrointestinally, what have you, it's mimicking sleep. And, there is a big difference between awake cardiac output and sleep cardiac output for all species, right? And so we're so focused on maintaining cardiac output, but it's maintaining cardiac output in the context of being conscious and or active. And that's not what's happening in our patients, which is why sometimes I see students, like they're starting to panic because the dog's heart rate might drop into the 30s. But I'm thinking to myself, like, this is a young, healthy dog. If they were also sleeping just normally at home in a restful state, that's probably what that heart rate and their cardiac output is like. So I always find this concern about cardiac output is a little bit disproportional because, like I said, this is a biomimetic state of sleep, essentially, from a physiological standpoint. They don't have that same cardiac output requirement when they are anesthetized.
I'm not sure that my cardiac output when I'm sleeping falls by like 30%, like to 30% of what it was like with Dexmed or like that dramatically. But at the same time, I also understand that we are providing fluid support, so we have other means to provide
Yes.
that organ
We spend a
perfusion.
lot of time fussing about what's normal, but it's normal based on consciousness, right? And we're working
I
in a scale
agree.
of consciousness.
I don't know what my mean arterial blood pressure, since it's a parameter that you focus a lot on, is when I'm sleeping. I hope it doesn't go down to the 30s or the 40s, but
No, but I also think too, like in
Seriously?
terms of dexmedetomidine, particularly for patients who are anesthetized, because it's very uncommon for you to only be anesthetized with dexmedetomidine, is that because we have multiple drugs on the table, like what you see with an awake patient, and if you were just to give dexmedetomidine and like you see that spike in systemic vascular resistance, we don't see that in the anesthetized patient, right? Like if I bolus you dexmedetomidine, you don't get hypertensive unless I've really like screwed the pooch. So, most of the time it's a foil for normotension, if anything.
yeah, I'm a little worried though that you do not see that because all the other systems are still like in place to actually keep the systemic vascular resistance at bay by decreasing indeed cardiac output, right? If you were to
Blunted
maintain
autonomic
your
response is one of our anesthetic parameters, right? So that's probably also why you don't see such like a dramatic explosion. But I do think,
That's an interesting
unless
question.
Ryan's going to go on his cat tangent, everybody buckle up.
Which ask the cardiologist about is the thing that we don't I don't know that we kind of gloss over sometimes is like so if we worry more about like the drug effect on cardiac output, heart rate, et cetera, but there's a whole system that we in certain patients, whatever, I'm not going to get into it, but in certain patients we can't control it all, and like their sympathetic tone can be super dysregulated. So you can have a cat 1 minute heart rate of 100, you know, you've got a map in the 40s, 50s. You get set up to do, dopamine, whatever you're doing, and you're getting it set up. The surgeon does something like pulls an organ or something, and all of a sudden, heart rate's well over 200. Map is now over 100. Like, is that better? is this system better with this completely dysregulated sympathetic tone? So your anesthetic chart looks like this with heart rate and blood pressure going up and down versus giving a drug that is going to modulate cardiac output to some extent. Like, to me, in my brain, and this could be wrong, I worry much more about this dysregulated sympathetic tone. I mean, we don't see, like, that being said, I don't see patients like drop dead, but like, why is that less of a concern for us? And you may not, that's like, this is not a question, a rhetorical question.
You
It
know,
happens
like,
all the time.
and we see so few cats under anesthesia as a primary service because interventions in cats are so rare. But at the same time, I don't know. I think that the answer that is when those adaptive systems become maladaptive, and I don't have an answer for that, and I don't know that anybody does, because
Yeah.
your anesthetic chart looking more flat may mean that your organ perfusion now is going like this, and you can sleep, right? Versus your anesthetic chart that takes into account pressure and heart rate mostly is going like this because actually their organ perfusion needs to be maintained like this. Does it make sense? Like those systems of changing those parameters are
True, but
in
you have to remember
place.
systemic blood pressure. There's sub autoregulation in most of the functional organ beds themselves, right? So even in the face of wild fluctuations, you maintain perfusion regardless. Like kidney, brain, heart,
Yeah.
lung, they all do that,
And
right?
that's why I'm saying, like, I don't know that the answer that we know that we can know the answer, because it's where is that slight barrier where adaptive systems become maladaptive, right? Where that vascular resistance increase that happens in healthy patients all the time, right? To maintain perfusion, then becomes maladaptive at a certain point because there's so much of it that you actually decrease perfusion to the organ, or when that is associated with also a decrease in systolic function, for which now you have a heart that is got like an obstacle to pump against and does not have the reserve that is your other side of that equation to pump against it. So I'm not sure that we're ever going to have the answer to that. I do, again, I'm probably a little bit more open-minded than many cardiologists, in which I don't like hard statements, particularly in the face of lack of evidence-based medicine. I'm not sure that for the Dexmed pulmonic stenosis thing that everybody wants to talk about, we do still have that solid evidence-based. Again, I think.
I guess what I'm really trying to drive at is when we look at some of these cardiovascular parameters, I'm not sure we know when the numbers become relevant, right?
Yeah,
That's really what I'm getting at. And so
I agree.
your cardiac output falls under anesthesia by 30%. We don't know the answer to how is that clinically relevant to the majority of the patients who leave the table. I mean, I see people, like, for sure, like anytime you lecture at a conference or do some seminars, people are super upregulated about acute kidney insufficiency, right? I've seen that once, and that was post arrest in a patient. You know what I mean? Like, that's
You've
not
seen like
something.
AKI post anesthesia once?
Well, I'm very, very good at my job, Giulio. But
Wow, you must
yeah,
be, like, really. Wow. Yeah, yeah. I mean, and again, it's not that we see it all the time, but like, yeah,
it was
now and again,
the
like the
patient had a
very.
rented kidney from a polytrauma anyway. So, I mean, it was a Euroabdomen drama. But anyway, these are the type of things like, and while we were talking to you, I did Google what your cardiac output falls when you sleep, and PubMed told me it was 26%. So yeah. So, but the thing is that what does that really mean, right? Like if you say cardiac output falls 40%, okay, sure, but my question is, so what? Like, do we actually have outcome numbers, long-term mortality, post-anesthetic? Like, what? And we don't, right? And I'm agreeing with you in the sense that we have to be a little bit cautious about being so conservative to the point where we're binding ourselves in terms of practice, particularly when we lack in vivo and we lack a lot of these studies to be done in patients who are already anesthetized, right? So Like that's always my thing. Like people shout numbers at me and I'm like, and where do we go then with relevance? Like, how is this relevant to me in terms of my patient outcomes?
Well, so some questions are better not answered. we may now want to find out what is the critical cardiac output for most dogs, but no, I agree. Like, nobody has ever shown that in a double blinded controlled clinical trial that furosemide does better for heart failure than not furosemide, if you wish. You know what I mean? But no, I'm being provocative now. Like, I totally get your point, and I would bring it back to particularly when you said about the AKI thing, to the level of care that these patients and monitoring that these patients receive. Because although it's true, if I think about it, that I've never seen in any of my patients that instance occurring, I can think of a lot of patients that get referred to us for AKI as a hospital level, and they have recently received an anesthetic event, right? In practice in general. And so I think that monitoring and the awareness of all these systems that come into play, it's awesome. But the conversation that we are having tonight are something that escapes a lot, like the vast majority of our patients, right? We are at the
Listen, nothing scares the anesthesia world more than the anesthesia that a lot of cases actually is happening. We're like 90% of our anesthetic cases are done in a GP level. And we have to remember that, like, and this is nobody's fault, but you go through vet school and you get 10 business days of anesthesia training.
Yeah.
Or not, or less, and you have people with no in vivo practice, going into these, debilitated senior patients who are having protracted, cohat procedures. And it doesn't surprise me that those do come off the table with AKI. So you're totally right. It's your sampling bias. But I think for the
dosing issue
cases, like our PSs and like our pacemaker placements and things like that, like when
there's also a dosing issue as well. Is like, you and I and Gianluca are gonna dose a lot differently than the RDVM down the street, who's had their 10 business days of anesthesia, and they're looking at the bottle and they're looking at the label dose, and for just singling out dexmedetomidine, there's a massive discrepancy in
it's huge.
what I'm going to give versus what the bottle of dexmedetomidine tells me to give.
Or even just like reference plums. And I always tell people,
Absolutely.
I'm like, plums is 3 to 4 years out of date based on literature. And people forget that, right? Like, it's not a real-time reference in the sense that, for example, like literature might be, or like referencing like people in the field. Like, plums is static and it gets outdated quickly, especially on certain topics. And so you might look up a dose. And the other problem is some of these dose ranges are big, right? Like ketamine, 1 to 100.
Probably.
Do you guys have that? Like, what is your target whenever you put a dog under anesthesia, and what is your timeline versus in a GP setting in which you got to get a dog down and get it intubated, and before you even start any instrumentation in, because like staffing is an issue. And so I do agree. And again, it comes back to the classic cardiac report recommendations that are sometimes overly, I agree, conservative, because they take into account these realities. And Gianluca has been at our institution, that I interfere close to none with anesthesia. And sometimes if I'm bored and I'm just waiting for my resident to do something, I will just peek and like, oh, what did you guys induce this dog with? But just because I'm curious, so not because I have an opinion about it. But when I write a cardiology report, I do take into account the fact that I don't know in which hands necessarily the dog is gonna end up in, and which type of monitoring, and so I'd rather err on the side of caution.
Monitoring is key, right? Like I always tell my students, like, in most paths, your protocol doesn't really matter. What really matters is that again, you know what the drugs do, and you know what to monitor and what to do if shit happens, right? Like that's key, right? Like, and unfortunately, again, and I'm a fault of this, like or everybody in academia is a fault of this, that we sometimes try to streamline the course and streamline the rotation for these students, and unfortunately 10 business days of anesthesia is not enough, like 10 business days of cardio is not enough either, right? And so I think that's kind of insanity, right? Like that we're pushed to shorten these rotations more and more, and these guys graduate without enough experience, and then maybe just to squeeze in an externship to Joe down the street, you know what I mean, where they basically not anesthetize them by hitting him in the head with a bat, and so yeah, and that's what they believe that's normal, right? I
We
literally
see
had a
a lot
student.
of we see a lot of the bias of also like, well, in the real world, this is what we do. Well, so it's like that's in
Yeah,
university
but
that
that's bullshit, right? Like, so,
or yeah.
but that's bullshit. I know a lot of people, they will say, hey, we don't show them this, we don't carry this because they won't see it in private practice. Now, that's stupid, right? Because by not showing them what's actually appropriate, we'll never advance. We'll never advance. Fucking VetMed is stuck to 25 years ago because of this, right? We're 25 years behind humans because we don't show the students what they could do to do better, right? And it's simple things, it's little things sometimes, right? We're like,
Yeah,
oh, we
sometimes little things. I think sometimes it's like cost plays obviously a role. Like, I don't know, I think 50-70% when I ask that stupid question because I'm bored, how are patients that get induced with a etomidate, and then I'm told, I guess, that that's kind of expensive and a lot of prior practice will not use that or things like that. I do have to give a shout out to our, I guess, at least in our area, our referral population is actually extremely good in both consulting with us and like understanding the patient. But obviously the reality out there's bad realities, although I have to say I think we're getting better at it, probably by that approach of showing our students how to do things better. But yeah.
yeah. And,
I've
and
got
again, it's
a
tough.
couple questions for you.
Is it about ketchup and
Uh,
hot dogs?
well, first of all, we'll start with the easy one. This may not be so easy for you, but what is if you were like, what is your favorite hot dog?
Favorite hot dog? What are you
I
talking
did
about?
not
Is
actually
that
think of that.
asking
I
to? Is there
I
different
Okay.
love
types of
hot
hot dogs?
I love hot dogs. I'm from Chicago. We have a fucking classic hot dog here. I know in Italy there's a hot dog with French fries pizza that's apparently for children. I had it when I was there. I enjoyed it.
Absolutely. Like
All
this
over
is
Italy.
like one of the most shocking things that I always tell people, that probably the second or third most common pizza in Italy is pizza with hot dogs. We wouldn't put pineapple on it, but actually pizza with hot dog, we call it like Vienne style, like Vienne, like the city.
Don't drag Vienna into
Pizza.
this. I'm
But
half Viennese, and we don't want to hear anything about the Austrians being blamed for your weird hot dog pizza. So
but wait, you're telling me that there's different types of hot dogs? What are you
Oh
talking about? Is
yeah.
it
Oh
Oh
yeah.
my God.
Is it
this
about
is
the hot dog
more
itself, or just
controversial
the
than
toppings, or
Dexmedetomidine.
the
Yes.
bread, or both? Like,
There's all of it. There's different brands. Like in Chicago, we have a specific style, but then we top our hot dogs with a bunch of stuff. So it's got tomato and onion and pickle and sport peppers and relish and mustard and celery salt. Oh,
yes,
it's so
the
good.
answer is yes. Yeah, put it all.
All
Yeah,
right.
Coronary artery disease
but
happening right here.
but then if you can do that and then chop it off and just put it inside a deep dish pizza, I think that would be great. That's it. That's Chicago's at its best. Right?
If anyone's gonna have coronary arterial disease, it's me.
There you go. There you go.
So, so
I did like when I was in Chicago. I did like the deep dish pizza.
The other question I had is more seriously. How would you like us, the anesthesia team, to approach the cardiac workup for these patients? Because I feel like that's the other point of contention is there's anesthesiologists out there who want to see an echo in every single patient they diagnose a murmur in.
I'll grow a set already. God.
It's not me. It's not me.
Yeah, we have good data about that for mitral valve disease, and I'm a little biased because our group has been working mostly on mitral valve disease, and so when we take into account the general population of dogs, things may be different. And then lately, that diet related DCM threw things a little bit off, obviously. But if we take those few instances out of the equation, I think we have very good evidence from thousands of dogs that if you take a population approach, understanding that we are talking about the average and 90 something percent of dogs, a small breed dog, small to medium breed dog that has a murmur that is less than a 3 out of 6, it's extremely unlikely to have significant heart disease, meaning heart disease with cardiomegaly. Okay. So we know that we have like very, very good chances if we echo the dog, and we know already that if we echo the dog, is going to have some mitral regurgitation, normal cardiac chambers. Okay. And sometimes we just do that. When people ask for a consult, and it's like, listen, I can tell you already by looking at the dog and I listen to the dog, this is what we're gonna find. Do you really want to spend $500-$800 of this honor on this? It's fair if they do because they want to be thorough. Because if you were a person, that's what they would do, honestly.
Yeah.
Like
Yeah.
they would do it all if money is not an issue. But at the same time, I think we have very good confidence for these patients that we know what they have, very good confidence that we know what they have, and we know the degree of severity of the disease that they have. Unfortunately, when it comes to other patients that are large breed dogs or cats, oftentimes it's really a coin toss, whether they have a murmur or not. To the point that we got into this discussion a few years ago with our neurology team. I was like, well, should we echo every Doberman pincher that needs an anesthesia for like MRI? And I'm not sure that that would be a recommendation, but remember that there is a reason why is called occult DCM until they are in heart failure. Because a dog, like a Doberman, could walk around with a fractional shortening of like 7% and be totally fine running in his backyard for real, and not have a murmur. The same for the cat with HCM. We know very well that there is about a third of cats with HCM that do not have a murmur, and a third of normal cats that have a murmur. And so, hearing or not hearing a murmur in a cat is a coin toss, right? I think we are a little behind in the use of biomarkers in some of these diseases. I think there is definitely a very good role of biomarkers in cats with HCM in a setting in which you do not have readily access to an echocardiogram. I think if you use it consciously with conservative cutoffs, also in dogs, we know that BNP that is below 1500, like that is above, sorry, 1500 in dogs is associated with like imminent heart failure or things like that. It's not super sensitive. While in cats, I think we have good studies that show that it's a relatively sensitive and specific biomarker for heart disease. So I'm not sure whether you would have to recommend a workup, a pre-anesthetic workup, a cardiac workup in every cat and in every large breed dog. I think it would be insane from the cost. But you would have to invoke that kind of population-wide approach for which we do our best. We work on likelihood of disease. We work on statistics, and even every time we use any drug or intervention, to be fair, I tell our owners, this is what works. On average, on the dogs, every patient is a single individual, which comes back to the monitoring, I guess, standpoint and recognition of you being in trouble early rather than later makes a lot of difference cardiovascular standpoint.
Yeah. No, that makes total sense. To follow up on Ryan's question, so
About hot dogs, I assume.
did you no?
Yeah,
It's about. Did you try tavern style pizza?
What?
what are you talking about? What? Tavern style pizza? What is
Oh my
that?
god! Oh my god! Oh my god!
Like Oklahoma thing? What is it?
I'll let you explain this, Beanie, since you had it while you
So
were.
like the very thin crust,
Yeah.
even more thin. It's literally like a cracker, but it's basically a pizza that's so thin and it's so crispy that it looks like a cracker, but it looks like it has all the pizza topping and all that shit, right? And so Chicago is divided in people that like dip dish and people that like tavern style pizza. So next time you go to Chicago, you need to hook up with Ryan, and
True.
he's gonna take you to A, try Chicago style hot dogs, and B,
Mhm.
the tavern.
I'm relatively open minded when it comes to food, to the point that sometimes I upset my eater.
Oh, and we cut it into squares like this, like a whole pizza cut into like squares, like a sewer
That's
bed almost.
totally fine. That's okay. Yeah, that's uh, it's all right. It's all right. I'm willing to try. It all comes down to the toppings, right?
Yeah, that's fair. That's fair. What's your favorite pizza topping?
Oh,
What's your favorite pizza?
I have like a wild varieties. I like what is called capricciosa in Italy, which has got like a lot of toppings, like capers to pepperoni to mushroom and artichokes, mostly with a tomato sauce.
Yeah, that's pretty
Sounds
good.
good.
But even like a classic pepperoni pizza is probably my go-to most of the times. I
Can you
actually have a pizza dough that I'm growing right now. Yeah, and
Oh
baking.
Oh.
wow,
Yeah,
ready
I'll be
to cook
ready for tomorrow.
pizza?
Yeah.
Yeah. What's your favorite toppings, Ryan? What's your favorite pizza?
I mean, tavern style, I'm gonna do sausage and giardiniera like every single time, like spicy sausage and giardiniera. And then if I'm doing like more of like an Italian, like
Napoleon style.
yeah, Neapolitan style, man, I don't know. What do I do? I mean, sausage is always pretty solid. I mean, I've tried my hand at doing like a margarita style with like sliced tomatoes. They come out too watery when I cook it in my like pizza oven at home, so I gotta work on that. But I like the simple, just like basil, cheese, olive oil. I'm pretty happy with that. Like there can't be enough basil in food for me, honestly.
What about you, Dasha? What's your favorite pizza?
I don't know if I have a favorite pizza, but my favorite topping is artichoke.
Oh,
Oh wow.
I really feel it brings out the flavor and gives it like a nice little like kick. It balances like the acid with the fat of the cheese. Yeah.
Absolutely.
Yeah. Yeah. My favorite is probably like quattro formaggi, which is basically
Or cheese.
mozzarella. Yeah, four cheeses, right? And but the four cheeses here is not the same as the four cheeses in Italy, because like here they don't use gorgonzola cheese
Correct.
oh,
because a lot of Americans don't like gorgonzola cheese. Um, but yeah, no, I love it. When we do it at home, it's legit. When I go out, I'm never eat it because like I know that's fake and there's no.
Oh, something that I always wow people with that a lot of pizzerias, well, not a lot of pizzerias have, you should try is mascarpone cheese with Parma ham, with like prosciutto.
That
Like
sounds
damn!
mascarpone cheese that melts and then prosciutto. And the mascarpone's got like the little sweetness to it
Do you put the mascarpone on before it goes in the oven?
after.
After? Okay. And then same with the parma.
Yep. Say
Ooh, you know what else I love? I love mortadella on at the end. Just like
that's another go-to for me. Yep. Yeah,
Yeah.
mozzarella, fresh mozzarella on top of it. Yeah.
I hate cooked mortadella. I don't know why.
Yeah,
Well,
cooked
it's not
mozzarella.
meant to be cooked, yeah.
Okay, good.
You know what
It
I
makes
hate?
you feel better. That makes you
When
feel
they
better.
put barbecue sauce instead of tomato sauce on the pizza. That I find that really disgusting.
Yeah,
Wow,
it's
that's like
gross.
that's like giving that
Barbecue
much.
pizza.
No, sorry, I was.
No, yeah. Instead, there's no there's no marinara, there's nothing. It's just barbecue sauce, cheese, and then they put barbecue meat on it, and I'm like, hell no.
What the
That
fuck?
sounds wild.
It's gross. Gross.
Whatever works for people, you know.
All
Whatever.
right, guys. I mean, we're coming up on the hour. Well, thank you so much, Giulio, for being here. Thank you for being a good sport with all of our, anti-cardio.
No, you're not anti-cardio. You're just anti-organ perfusion. That's great. Anyway, sorry.
No,
Nice, nice.
actually, you know what it is we're anti other people telling us what to do. It's
True.
really, it's really.
That's true. We are control freaks to the max.
Mm-hmm.
Yeah.
There you go. There
And I
you go.
certainly don't want two-bit opinions on anesthesia from fucking ER interns.
Well, thank you so much, everybody. You can listen to this on a lot of platforms, but you can also watch it on Apple Podcasts and YouTube. Thank you, everybody. Have a good night.
Good night. Bye. Thank you so much.